Welcome to Diabetes Day by Day, the American Diabetes Association's official podcast. The management of diabetes, high blood pressure, cholesterol, obesity, and other chronic health issues is certainly challenging. The goal of our podcast from its origin has been to empower you with knowledge. We all know the old saying, knowledge is power. Well, today we're going to discuss the resources available from the American Diabetes Association and the American Diabetes Association's new division, the Obesity Association, that helps us accomplish those goals, that empowers you all with knowledge. I'm Dr. Neil Skolnik, professor of family and community medicine in the Sidney Kimmel Medical College of Thomas Jefferson University, and joining me as always is my co-host.
Hi, Neil. New year and new divisions to talk about, and certainly some new standards. I'm Dr. Sara Wettergreen, an associate professor at the University of Colorado Skaggs School of Pharmacy and an ambulatory care clinical pharmacist.
Sara, as long as the ADA has been around, they have had a really strong commitment to ensuring that the best and most updated medical information is readily available, both for people with diabetes, people with obesity, people with cardiometabolic disease, as well as the clinicians like you and I that take care of them. You know, when I say that, it may sound like an easy task, but it actually takes a lot of people and a lot of effort to make sure that the information is accurate and that it's readily available. Can you tell us, Sara, about some of the resources that are available?
That's absolutely right, Neil. And I'd love to chat with you about those resources. And thinking about the work to put those resources together, it is no small feat. As a clinician myself who uses the standards of care from the American Diabetes Association in my practice and shares them with people living with diabetes that I interact with, I appreciate all the effort it takes to make these resources come together. So let's chat a little bit about each of the standards of care. First is the standards of care in diabetes. This is the original resource. It has been around since 1989 and is updated annually. It includes all current clinical practice recommendations of the American Diabetes Association. And what's really most impressive to me about these standards of care in diabetes is the annual update. For comparison, as you and I know, Neil, other clinical guidelines for other topics might be updated every 3 years, 5 years, or even longer. So the annual update shows how quickly care is evolving in diabetes, but also reflects the tremendous work done each year to make these standards come together. Another resource is Your Rights and Care Standards, a guide for people with type 2 diabetes. This was newly released in 2025, so newer, not as long as 1989 compared to the standards of care in diabetes. But this resource is based on those standards of care in diabetes, which are oriented towards clinicians, but are presented as clear, easy to read and understand information for people living with type 2 diabetes, as well as their caregivers or family members. When I think about the goals of this resource, I really think it parallels the goals of our podcast for Diabetes Day by Day, which is to provide actionable information to empower people with diabetes to engage in their care. The last resource, which is hot off the press, is the Standards of Care in Overweight and Obesity. This is a brand new resource which is oriented toward clinicians and is focused on pharmacologic or medication treatment of obesity in adults. Thinking about this and knowing now more than ever, medications have become part of a comprehensive care plan for adults with obesity. The standards of care in overweight and obesity provide evidence-based guidance to clinicians as they support people using these medications and treatments for obesity. So thinking about this, wow, we sure have a lot of information to talk about today, Neil.
We sure do, Sara. And to our audience, we're going to cover some highlights. The most important thing is that you know these resources are out there, because obviously we're not going to cover all of the information in all of these resources, but let's take them one by one. And let's start with, Sara, can you give us a sense, what is in Your Rights and Care Standards, a guide for people with type 2 diabetes, and how people with diabetes might use those standards?
Yes, absolutely. It really is this hands-on, actionable resource for people living specifically with type 2 diabetes. It is more oriented towards type 2 diabetes. If you're looking for the resource in Google or going to our show notes to find it, the official title is Your Rights and Care Standards, a guide for people with type 2 diabetes. This guide focuses on three key pillars, which are all part of type 2 diabetes management. These are medical support and care, healthy eating, and physical activity. The things we probably would think of as being those three pillars of managing type 2 diabetes. Diving a little bit deeper, the pillar of medical support focuses on medications, glucose monitoring, and checking for complications of diabetes, which could include kidney or heart disease. The pillar of healthy eating highlights some key dietary recommendations and resources for support. And finally, the last pillar, which is physical activity, emphasizes the aim of at least 150 minutes of moderate intensity physical activity per week. What I really like about this resource is how actionable it is. I really think of it more as a handbook. It has different charts that someone can fill in as they read, different tables and notes you can take, and it even has a page at the end focused on questions to bring to your next visit with your diabetes healthcare team. Thinking about all that, the emphasis of this resource is really focused on patient empowerment. It focuses on how the person who's living with type 2 diabetes is in the driver's seat of their care plan and helping them be prepared to drive that visit the next time they have a care visit.
Yeah, Sarah, I found it fascinating in the way they organized it, is that there's a lot of space if you print out the PDF to write in things like you mentioned your questions or you write in your immunizations and it really is an interactive document that can be used to help organize your care as you go in to see the clinician that is taking care of you.
I love a checkbox and a to-do list, so that resource makes me really happy. And if you're someone who might benefit and you have type 2 diabetes or you're living with that, I would encourage you to check it out. Now, Neil, moving to our next resource, can you tell us about the American Diabetes Association's Standards of Care in Diabetes? And starting off by telling everyone how those get put together.
Yes, Sarah, this is, I think, one of the most fascinating aspects about the standards of care that has always been important, how carefully put together it is, how carefully based on the evidence. And as much as that has always been important, in this age of misinformation and mistrust, it becomes critically important to know how recommendations are put together, are made, what goes into them, and know that they're based on the best evidence out there. These are recommendations you can trust. So what goes into both the standards of care for diabetes and the standards for obesity and overweight is a very similar process. And it starts by selecting a committee of experts. Those committee of experts are recommended by their peers and then have to be improved by something called the Professional Practice Committee of the American Diabetes Association. They then begin reviewing evidence, new evidence that comes out the day after the standards are released. So this year, once the standards are released, are ready. That committee, that group of people, are looking at the literature to assess evidence. A few years ago, the standards that were published and are published annually actually were changed into what are called the living standards, so that if a critical article comes out, if there's a critical change in the approach to things, we no longer wait a whole year to let people know. That is published when it is relevant, when that comes out, and when consensus is made among those on that practice committee that it should be communicated to clinicians at large. The committee meets regularly through the year virtually. It also meets in person, and they come up with the revision to the standards of care. And this is not done lightly. Those recommendations are done by the committee and then have to be voted on. And it's only when a majority of the experts, and it's usually more than a majority that agrees something's important, but only when a minimum of a majority agrees that the evidence supports a change in recommendation, that that recommendation makes it into the standards of care. And then those recommendations, so that you and I know as clinicians what's going on, is given an evidence rating. Is it an A, B, C? How important, how certain are we of the recommendation? So these standards, both with regard to the diabetes standards and the obesity and overweight standards, are simply rock solid, and we can trust them and depend on them.
Yes, you absolutely can. And I think after hearing more about that process, hopefully our listeners can understand why that annual update is so impressive. Such a rigorous workload year after year. And as Neil said, the work begins the day after the other standards are released and is continual now that this is a living document as well. So, thinking of that, let's talk about some of the most important changes in this year's standards of care in diabetes. Why don't we share a couple of highlights? Neil,
Yeah.
you go first.
Okay, Sarah, and this is going to be moving quick because these are just highlights. There's a lot there. One of the ones that stood out to me is with regard to what is called MASLD, or metabolic associated steatotic liver disease. That's a big word. It's what used to be called fatty liver, and then metabolic associated steatohepatitis. That is the acronym is MASH, used to be called NASH. Again, all different versions of fatty liver disease. And the big change here is that for people with diabetes who also have MASH, a GLP-1 with demonstrated benefit is the preferred glycemic management medication. And this should be taken into account to think about a GLP-1 in anyone with MASLD, again, with fatty liver. So this is really raised in importance from what used to be. Sarah, anything stand out to you?
Well, that was certainly a highlight, Neil. One update that I was excited about, being a diabetes technology person, is the expanded indication or use for CGM. So the standards now say that using CGM is now recommended in people with diabetes who are either on insulin or on non-insulin therapies that can cause low blood sugar, and for people who are using any diabetes treatment where CGM might help in management. So, thinking about that and thinking of the history and progression over time, we used to see that CGM, or continuous glucose monitoring, was indicated and used for recommendations in people using multiple insulin injections per day. Then that evolved to people using insulin. And now that's evolved to people using these non-insulin therapies in any regimen. And so this really just goes to show that there's expanding levels of evidence for using CGM in patient care and in the management of diabetes. And now that might open up doors for broader insurance coverage and more access. So I was really excited to see that change this year.
I agree with you. I think that was really a big deal and really important and supportive of what we like to do. In the same area, I noticed in the diabetes technology space, they're now mentioning the use of automated insulin delivery systems, which used to be just in the area of type 1 diabetes, now also recommended for people with type 2 diabetes on multiple daily injections of insulin, as well as people with type 2 diabetes on basal insulin who are not meeting their individualized glycemic goals, and can be even considered for anyone with type 2 on any type of insulin. Sarah, you're a pharmacist. Let's move on now to medications. What do you notice there?
Well, there were so many important updates in regards to medications. You already highlighted one of them, but another one I'd like to highlight is related to obesity management, actually. So, the standards of care in diabetes have a new recommendation for obesity management in adults with type 1 diabetes, which includes consideration of a GLP-1 receptor agonist, so medications like semaglutide. Overweight and obesity, we know, occur at similar rates in people with type 1 diabetes compared to the general adult population. But we know that people with diabetes have this additional cardiovascular risk factor. And so this new recommendation demonstrates that there's more emerging evidence to support the use of this class of medications, the GLP-1 receptor agonist, for weight loss pharmacotherapy or obesity management in people living with type 1 diabetes. I thought that was a big change.
That is a big deal, Sarah. Any others that stood out to you?
Another one that I think is a little bit of a shift in topic, but was a big change that stood out to me was a change in systolic blood pressure goal recommendations. In the cardiovascular section, the systolic blood pressure goal was reduced to less than 120 millimeters of mercury for people who have high cardiovascular or kidney risk. So, this is a big change in practice that systolic blood pressure for our listeners is the top number when you check your blood pressure. And most of our goals and other standards have said less than 130 there. And these standards as well have said less than 130 for many years. So, this shift is not for everyone. But it is for individuals to consider if they do have high cardiovascular risk or if they have kidney disease. So if you're a listener and you have diabetes and you're taking blood pressure medication, this might be something to think about or bring up to your provider to see if that goal shift might be something that would be appropriate for you.
Really good point. And there are plenty of others. One that stood out for me, we've talked in this podcast before that about 20% of people with type 2 diabetes do have heart failure. And the GLP-1 class of medicines, both semaglutide and tirzepatide, are now on the map along with the SGLT2s that have been for a while for people with heart failure. And also now the GLP-1s are there for chronic kidney disease as well. So there are a lot of changes, and this is something that we work hard to keep up with, and people can see as we just cover, we're just skimming across the top how much work goes into putting these evidence-based recommendations together. Let's go on now and briefly talk about the ADA's Obesity Association's standards of care. And that same careful process that we talked about is used in the obesity and overweight standards of care. And what stood out to me here, and this may seem, maybe obvious, but I think it's really important, is that we now have an official guideline to manage obesity. And what I like about it is the opening statement. And here I'm going to quote: obesity medications are an essential component of a comprehensive approach to obesity management, offering significant benefit beyond lifestyle interventions alone for many people. And what that means is it basically reaffirms lifestyle is critically important. We all agree, and this has gone over a lot in the guidelines. Following a good dietary pattern is critical. Exercise is critical. The guidelines reaffirm that obesity is a chronic disease, and as such, it requires chronic management, with lifestyle always essential and medicines often needing to be important as a part of that management as well. Sarah, what stood out for you?
Gosh, Neil, I agree with you. This is really an essential resource. Medications to treat obesity are really not just about weight loss. They can also improve the cardiovascular and metabolic consequences of obesity, from high blood pressure to sleep apnea to osteoarthritis, for example. We know that obesity is a chronic condition, and thinking of a holistic care plan is that's needed to consider all of these person-specific factors. These standards talk about creating individualized goals and using a patient-specific approach called shared decision making when deciding between different medication options and selecting therapy that's based on a person's individual characteristics, such as any complications of obesity they might have. So something that stood out to me is how person-centered that these standards are. When I think about practice within obesity care, I would say historically, weight loss medications may have been prescribed by specific weight loss clinics or obesity clinics. And I think more than ever, we're seeing obesity medications prescribed in a primary care office with your usual care team. And now that I see that, I think having additional guidance through these standards of care in overweight and obesity to provide information and guidance to ensure this comprehensive care of obesity management is the focus, and we're not just looking at the medications, we're looking at the whole person, is important. And that includes monitoring and follow-up timing and thinking of the other components beyond medications, as you mentioned, Neil, the dietary components, the exercise components. So there are so many different important components of this that stood out to me. What about you, Neil?
Oh, I agree with you, Sarah. And one of the things I was happiest to see was their emphasis on a holistic approach to care. And a part of that is regular follow-up, as you mentioned, with the clinician that is prescribing this, that these medicines are not utilized to their fullest if it's just obtained over the internet from someone who never sees you again and doesn't monitor your care. In fact, the guidelines suggest that for a while after starting a medicine that people are seen at least every 3 months to see how they're doing. And then they also get specific about certain aspects of lifestyle. Things like preservation of muscle. We know that when you lose a lot of weight, you don't just lose weight from adipose tissue or fat, you lose weight from muscle. A lot more from fatty tissue than muscle. Nonetheless, you lose about a quarter of the weight that's lost is from muscle. There's an emphasis on preservation of that muscle by resistance training. That's things like bands and or weights. Adequate protein. They mention a minimum of 60 grams of protein daily, although higher protein is often useful during times of particularly fast weight loss. They talk about adequate daily intake of water. They talk about adding a multivitamin and mineral supplement as a consideration. And again, that careful follow-up. So there's really a holistic approach. It's not just about medicines. It's not just about weight. It's about health, feeling better, and doing better over time. Sarah, speaking of time, we are about out of time for our podcast. Do you have any final thoughts for our listeners?
Wow, so many final thoughts between all of these different standards and resources. But the biggest point I would say I would like our listeners to take away is if the patient standards of care apply to you and you're someone living with type 2 diabetes, I definitely encourage you to check those out. If that doesn't apply to you or you want to learn more about these other resources, you can, of course, look at the resources directly and then certainly work with your medical team to see, is their practice aligning with these standards of care in diabetes and standards of care in overweight and obesity? Are you getting frequent follow-up? Do you need additional support? Would referral to a dietitian be helpful? So continuing to reach out to your care team, ask your questions. I want you to feel empowered to engage in your care.
Sarah, you said it. It's all about empowerment. It's about having the knowledge that allows us to help with our care, be the center of that care team. Sarah, I also want to take this opportunity to say thank you to you for the incredible work that you've done over the last 3 years, both launching and co-hosting Diabetes Day by Day. This has been an important resource for all of our listeners, and I know that your increasingly busy schedule has led you to make the difficult decision to step down as co-host of this podcast. I want to say I will personally miss talking to you every month and hearing your insights. I've learned a lot from you. But I also understand the need to regularly reassess responsibilities to maintain balance in our life. In fact, I think that probably is going to be a good topic for a future episode. So, Sarah, thank you so much. And to our audience, we hope this episode has given you practical information and resources to further empower you in your health journey. For the American Diabetes Association, I'm Dr. Neil Skolnik. Thank you for listening.